All right, and we are live. Thank you everyone for joining us. Those who stuck around, we had a little bit of a late start. It's been a busy day. Um, I'm Mason McGrew with Kaleidoscope Marketing. I'm going to be the tech guy today, so I'm going to make sure that nothing falls apart. Hopefully, nothing does. And today's event is myopia management for your child. How action today protects vision tomorrow. Sorry, I'm gonna stutter a little bit here, running off the seat of my pants here. Um, First, I've got like people texting me right now. Sorry. I'm going to send it to our first speaker, Dr. Steve Ferguson, the owner and vision medical director at Dunes Eye Consultants and Dunes LASIK Center. So if you want to
Hey, great. Well,
send it
first of
off.
all, I would like to thank everyone for taking time out of their busy schedules to join us. It's an important topic. That's why we're making the effort to start getting information to parents about the new norm in taking care of the child and the impact today of what that means. I'm delighted tonight that we have Ginny Mercer from Coopervision that's got a specific targeted research-backed program that she's going to share with us tonight, among other means of helping therapeutically slow down nearsighted vision changes in your child. Dr. O'Neill is with us, and Dr. O'Neill has taken the leadership role at Dunes Eye Consultants for myopia management for a couple of reasons. One, he was at the University of Houston, where much of the research was performed over the years to identify how to stop and slow down progressive nearsighted changes. So it was a natural for him to take what his training and experiences were and start implementing that into private practice. And he's a lot younger than I am, so he's seeing a few more younger patients. So it is certainly a natural. But it's been a strong interest of mine as well. We've been utilizing a procedure called corneal reshaping to actually help patients avoid the need for glass and contacts during the day. We started that 15 years ago, and over those past that decade, we were experiencing the fact that patients' eyes were not changing, and the research back that supported it in this particular type of treatment modality. And you're going to learn tonight about several different treatment options, and we try to tailor what's best suited for your child. So I think that sort of sets the stage. I'd like to turn this over to Dr. O'Neill at this point to get a little more information out to us. And when you're ready for us to show some diagrams, Dr. O'Neill, shoot it back.
Got it. Thanks, Doc. Sorry for starting this late, guys. It was my fault. I was actually with the patient who was doing myopia management, so it seemed appropriate. So a couple big topics. When we're talking about myopia management, we're actually talking about what a lot of people will call it nearsightedness. What nearsightedness really breaks down to being is the eye has grown longer than the eye is supposed to be. That's the easiest way to think about it, and that's what causes distance blur, typically starting in kids. And the age of when it starts is really important, mainly because the younger kids become nearsighted, the more likely their prescription is going to be larger and larger. So big picture is the eye being longer than it's supposed to be. We know that in the last really 35, 40 years, the number of nearsighted people in our country has doubled, which doesn't really happen just based on genetics. Nearsightedness there is a genetic component. Parents with nearsightedness definitely have a higher risk of having kids with nearsightedness. But the biggest thing that's changed in the last 40 years is how we use our eyes. The up-close vision that kids are doing at younger and younger ages, tablets, cell phones, iPads, and very obvious with COVID, how the way kids use their eyes is not even close to the same as it was 40 years ago. That's been the biggest change, and it's directly correlated to when you look at the nearsighted or myopic statistics in this country. It's almost like a wall where it's just kind of flatlined, and all of a sudden it just goes all the way up, and that's directly related to the invention of all our nearsighted devices we use. A couple big things. The obvious thing when parents have a kid that becomes nearsighted, they're becoming dependent on some kind of optical device. And usually it's glasses, and especially young kids. And that's one thing. It's kind of frustrating. It's frustrating for kids who have to wear glasses in sports or activities or even just school to see the board. And then, of course, kids get to an age where we can put them in regular contact lenses and we can make them see well. But one thing a lot of parents will notice is every year they come in, these nearsighted kids just typically get worse. Their prescription gets bigger, their glasses get thicker, and along with that, the dependency on spectacle correction increases. The higher the prescription, the more likely kids just can do less and less without their glasses on. And then as a doctor, it's annoying for parents to have to get new glasses or contacts every single year, prescription change. But as a doctor, the more important thing for me is as the eye gets longer, the risk for those kids to develop eye problems or diseases increases exponentially, especially as they get older. It's not so much that the kid's going to have an eye disease as a child, but the risk of those kids developing certain diseases that we'll go into as they get into their 30s and their 40s and their 50s just goes up. So as the doctor, that's my first thought of, if I can decrease your risk of a couple big diseases of glaucoma, macular degeneration, retinal detachment, those are a couple of the big ones that we always were talking about with nearsighted eyes. If I can decrease that risk by more than 50%, that's the most important thing we're doing for these kids. Let alone it's nice for the kids not to be dependent on glasses. We'll talk about a couple different treatment options that we can be doing. But really the risks of in educating the population, most parents and even most just people don't understand that nearsightedness is anything more than an annoying problem that we can fix pretty easily with glasses. And that's really going to be the importance of us going through these webinars and discussing with people and parents, is helping people understand that it's not just a mild problem. It's something that's going to cause problems as these kids get older if we don't take care of it now. So there's a couple ways we can do this. Two big options are contact lens related, and Jenny, I'm going to turn it over to you here in a minute. She's going to go into something we call MiSight, or the MiSight lens, which is the only FDA-approved treatment for myopia management. Another one Dr. Ferguson mentioned was ortho-K or CRT contact lenses. Optically, these contacts work very similar. Without going into too much detail, it really tells the eye to stop growing at the same rate by using peripheral vision defocus. What that really means is kids can still see very clearly. They don't notice any blur changes, but by changing the way the light lands on the back of the eye without making them blurry, we tell the eye to stop growing or slow the rate that it's changing. The third option actually involves just a simple eye drop. It works on a different mechanism of action, and it's scientifically it's the least effective, but it's also way more effective than doing nothing. So that's just a kind of quick overview of those couple things. And I'm going to turn it over to Jenny, who is our dedicated myopia management specialist. And she's going to give us really a little bit more optics and discuss the MiSight lens a little bit more. Jenny, go ahead.
All right. Well, thank you, Dr. O'Neill. I appreciate you guys having me here today. And hello to all the parents out there and decision makers of these kids that we're going to be talking to and about. At coopervision, we are really pleased and honored, really, to be able to offer you all the only FDA-approved treatment lens to slow your child's myopia. Please keep in mind, there are many other FDA-approved contact lenses. However, none of those were specifically designed to slow myopic progression in children. This is really a lot of breakthrough in technology that we have, and this is something in the eye care field that we have not seen prior. So I'd like to take a minute and show you what this technology looks like and how it works. So this is an example of the lens design and its very unique properties. If you're looking closely, you can see there's two purple zones and two dark purple zones. The light purple is where your child's prescription is. That's where they're going to see. The dark purple that you see is the myopic defocus. Dr. O'Neill had alluded to that earlier with the CRT and the peripheral defocus. So most all of our myopia managements work off of defocus. So with these two zones, it enables your child to have clear vision and a myopic defocus, which is going to help reduce that prescription from getting stronger and stronger, and of course the eye growing longer. We at coopervision call this active control technology. Now, the active control technology is giving your child 360 degrees of clear vision in all gaze ranges, and 360 degrees of myopic treatment defocus. You're looking at the diagram with me here. You can see as that light enters your child's eye, they're going to get that clear vision in those ranges. Also, you're going to get the myopic defocus. And what that's doing is it's redirecting where that light is hitting on the eye. So it's resisting it to grow longer and resisting that myopia, the strength of those glasses, to get stronger and stronger. So this is, of course, going to make those long-term implications less later in life. At CooperVision, we did a very rigorous 7-year clinical study. This is how we obtained that FDA approval. And we're going to look now at the actual effectiveness of how this lens works. This graph demonstrates the science and data proving the effectiveness of MiSight, showing a 59% reduction of prescription for the children that were in MiSight, meaning, for example, if you had a prescription that was a -500, maybe it would have only been a -2.25. Now myself, I'm myopic. I would have loved to have this as a child. I didn't. So I am on that other range with Dr. Ferguson looking at ocular issues. So again, this is something very unique that we now have in your doctor's offices. Also significant is the reduction of the axial length growth. This is, of course, where the eye gets longer because of how the light was entering it. The children in the MiSight treatment lens demonstrated a 52% reduction. Again, less ocular risk going forward. Overall, the MiSight treatment lens and Brilliant Futures program will offer your child a life-changing opportunity and a positive effect on their vision, not just today, but in the futures. So I'm going to go ahead and put this back to you, Dr. Ferguson, and happy to answer questions at the end.
Jenny, very, very good. Thank you. And we're honored that we were selected initially to be part of this Brilliant Futures program. It is an extremely well-coordinated program for this FDA device. And so we're excited that we can offer that as one of our treatment options for patients. And patients that are getting involved with it, there's so much interaction with coopervision with this that's really powerful. I want to talk a little bit about what the future means when we talk about potential vision loss. And there's really 4 particular conditions that can develop. And I also want to let you know that I have glaucoma, and I have glaucoma at a young age. I'm in my 50s, and I'm also nearsighted. And my father also had macular degeneration. And 2 of these 4 conditions we're going to talk about. So the question that goes through my mind is, if myopia management would have been available 30 years ago, 40 years ago, would that have reduced my risks for developing, number 1, glaucoma and also macular degeneration later in life? So I'm a patient too, okay? And so now we want to bring up the first slide that we have on glaucoma. And what you'll see is there's a figure to the left, and it really shows in the top left box kind of what a normal eyesight should be. It shows to the right some cloudiness that is related to something else, like a cataract. But the bottom 2 boxes apply to us. On the left is what happens in myopic degeneration, where the eye elongates to the point that its central tissue is so thin that it can't function properly, and you lose central vision. That's also the same impact in macular degeneration. So when we get older and we have weak tissue, the same thing can happen, and we lose central vision. In glaucoma, the opposite effect happens. We lose our side vision. And so when you look at that picture, you're seeing that there's very limited visual opportunity because of the glaucoma that's developing. So you can see these 2 potential blinding components that are related to the conditions. Glaucoma to the right, this is a very simple slide, or 2 pictures of slides that show that the optic nerve in a healthy patient is kind of like a little pink donut. But in glaucoma, we lose the rim or the donut, and all of a sudden we're left with this white big cup. That's what happens clinically in glaucoma. In macular degeneration, we see this loss of tissue centrally. So you'll see that, like the diagram to the right shows a normal looking eye and where the macula is at. The macula is the most sensitive part of our visual system, and 1 out of 4 individuals age 70 will develop this. So it's a very, very common ailment as we age. So anything that we can do to reduce the risk of that developing later in life is very, very important. And then if we look at something a bit more catastrophic, retinal detachment. Retinal detachment, you can see these 2 images where that one on the left is a post-surgically treated retinal detachment. That is a significant surgical experience where the patient has to have basically a buckle put around their eye to reattach the retina. And then in the diagram, figure 2, you'll see that there's like a storm, and that's a detached retina. These increase the risk of getting retinal detachment increases the thicker the glasses, the more the correction. And so these are real live events that we see in our practice very routinely. The last slide is coming back and showing you myopic retinal degeneration. And you can see the slides of what, in the images on the left, there's a sort of a breakdown. Think of it as the carpet's just getting thin. And when it thins out, there's no little cameras to take a picture. And the result is loss of vision, primarily centrally, like we show in the figure 5 there. So our practice was founded on 2 things. Everything we can do to protect the gift of sight, vision preservation, and number 2, using the most advanced technology that's FDA proven or proven by studies to support our care for patients. So myopic management is now the new norm for us. Anytime we see a patient that's in the office that shows some change, we're going to hand them a little document that shows where their level of nearsightedness is at and what their risk of getting these conditions later in life. That's our informed consent for our patients. Then we give them the information about what they can do next to preserve their vision correction for their child at the state that they're in currently, but more importantly, protecting against getting these adverse events later in life. So it's a lot. It's a brand new thought process, but is now the new norm and standard that every patient deserves the right to have this experience. Dr. O'Neill?
Great job. One thing I wanted to touch on was because there are some kids, we'll see kids who are 5 or 6 who come in and they're already nearsighted, and that's a big deal in our world. But a lot of these kids aren't ready for contact lenses. We've actually been involved with the study for the last almost 3 years already on a spectacle correction. Now, this is not FDA approved yet, but it's been pretty fun to work with this glasses technology. I believe we were one of 17 sites in the whole country, and I think it kind of helped open our eyes up to how important this is and how young these kids are getting it. So for parents who, they're thinking their kid's 6 or 7 and they're not ready for contacts, I don't want them to think, well, there's no option until they get older. There's always an option. And like we talked about earlier, the eye drop is always a very, very simple option. Usually my 5 and 6 year olds who aren't ready for contacts, they're getting put on the drop to start. And then as they get older, we either transition them to one of the 2 types of contacts that we talked about. But overall, Doc, I think you did a great job explaining the diseases and why we see it as such an important thing to discuss with parents and how they can expect to hear about it every time they come in with their nearsighted kids.
Great.
All right. I think we covered everything. Do we want to go to questions now?
I will make a summarizing comment to Dr. O'Neill's statement, if that's okay.
That sounds perfect.
Hey, so what Dr. O'Neill touched on was the continued evolving technologies that's going to expand our opportunities, and being part of the sight glass study for myopia control with glasses is going to be a gigantic extra component of raising awareness and helping. And then there's more choice, and any patient that has nearsightedness is going to have a treatment option in the very near future, drops, glasses, and different types of contact lenses. And so we're very excited about that. I'm glad you brought that up, Dr. O'Neill. That was a great point. All right, well, awesome. Any questions, we'll take them if we can.
Yeah, we got people watching right now. I'm looking at the chat. Don't see any questions. Oh, we got one question. is it tough to get kids to cooperate with the program?
I'll take that one. So far we've had nothing but good feedback. And like I just touched on the contact lenses. There are some kids who aren't ready for contacts, and if that's the case, then we have to do something else. But the treatment we have an option for essentially every kid that's nearsighted at this point in time. And then a big part of the program is monitoring not only the length of their eye, but their prescription. And that's something we do on a day-to-day basis on very young kids. So and kids are pretty adaptable. We've really had no problems with kids in the program. It's honestly, the biggest thing is just educating the parents and helping them to understand why we're going over it. But I put a 4-year-old in contacts the other day, and then the last couple have been 7 or 8, and most of those just no problems at all. It takes some training, and one of the really interesting things is there's actually a couple studies now that show younger kids are less likely to have any problems with contacts than adults. And it may just be because parents are helping them, or kids are just, we teach them very appropriately and they're not abusing their contacts. So that's always nice for parents to know, because there's no such thing as no risk when we're talking about any treatment or contacts. But the fact that the risk of a daily disposable contact is less in a child than even a monthly contact in an adult, which is nice for parents to hear that.
Great. All right. And kind of to go off of that, are there any like main reasons reasons for why parents should be more aware of myopia?
I didn't catch the question.
Oh, sorry. I'll say it again. Is there like 3 main reasons why parents should be more aware of this?
Well, no doubt. I think the fundamental one is to protect their child's eyesight for a lifetime. That's number one, reducing risk of getting catastrophic eye disease that could lead to blindness. That is a fundamental statement. And number 2 is to allow them to stabilize their correction so that they're able to function with their optical device, whether for myopic control, if it's a contact, whatever, more effectively. The thicker the glasses, the more disturbing it is to the visual system, or contact lenses are more problematic and higher corrections. But here's one that's really interesting, and I deal with it now on a fairly routine basis. By stabilizing the visual correction for the child, when they reach the point when they can have refractive surgery, it's a much easier vision correction surgery if the patient's mild to moderately nearsighted than super advanced. And we're seeing that as the fruits of our initial CRT ortho-K patients from a decade that are now eligible for refractive surgery age-wise, and they're in an easy case for us. And so that's one that's often lost, but it's a pretty important part of it.
Awesome. Well, I think there's only one more question that I can see in the chat, and that is, how affordable is the treatment?
That's a great question. Would you like me to take that, Dr. O'Neill?
Yeah, go ahead.
So and Dr. O'Neill and I have spent an enormous amount of time working to put into play this treatment. When you think about braces, and that's the analogy that's often made, that myopia management is essentially like braces for the visual system. There are some developing programs out there across the country. We looked at those programs where they have it's like a box. They come in, they have everything set up, and they're a turnkey, and they have education. But we've looked at the pricing structure of that, and as we thought about as us as consumers and parents, we tried to figure out what makes the most sense. Brilliant Futures was very helpful in establishing a fee structure as well that makes sense for the vast majority of patients. So that when you think about the costs annually of contact lenses as well as glasses, then you add on the myopia management, it is an affordable program. And it's one where our treatment programs are pretty much the same across the board, so that we can pick and choose for the patient what's best for them and not worry about cost or price. And so we feel extremely good about the value that these can bring to our patients. And I think that we're finding that most patients, when presented, or when patients or parents are presented, that they're saying, hey, yeah, this makes a lot of sense.
That's awesome.
Jenny, I'm betting that's something that you have to talk a lot about, is cost. Do you want to touch base on that also?
Absolutely. Thank you. I will. first of all, I'm a parent, as you guys are, so I look at that myself. But the bottom line is that when we are shown that a treatment is valuable and we can see what that end result is as parents, again, to your points earlier, talking about it, making sure they understand it, those families are going to do whatever is possible to make that work. And you look at, something that it's like you go into the phone store, right? They don't tell you it's going to be $3,000 a year for your phone. They say it's going to be about this much per month, right? So there's different ways that it can be formatted to explain it. But when we have a myopia management program, typically it is a flat fee, and it's a lot cleaner to look at in that regard, because then, the families know this is my treatment program. This is what this fee is going to be. They know what it includes. They see the value in it. And they also understand that this is helping their child long term. So the fees themselves really become like braces in as much as that we want to keep that stability there. And so we want to make sure that we're keeping those kids in those treatment lenses until they're ready to be taken off of them. To Dr. Ferguson's comment, LASIK procedures or something like that. But the fees overall, I feel when I look at them and how we've got them set up with MiSight and Brilliant Futures, they make sense because it's an easy format to follow. And Dr. O'Neill, are you finding that in your practice as well?
Absolutely. And I like the braces analogy, and we use that quite a bit for all of the treatments, really. And it's easier for parents to understand. They know if their kids have crooked teeth, it's not really a question. It's when the dentist sends them over to get braces. And that's going to be where myopia management is. Actually, I think it's going to be relatively soon. But that's one thing as parents come in, they're learning this for the first time. It's education. And that's really our job, is making sure the parents and the kids understand it. But it's really a conversation with the parents. But that braces analogy is helpful. And I think orthodontia, they've done a great job. And we know if my kid has crooked teeth, this is what we're going to do. That's what myopia management will be. Parents will come in. They will know, my kid's myopic or nearsighted. Okay, which one of these treatments is best for the kid? And that we're just going to be moving into it. It'll take a couple years of education there, but I truly believe this will be something that's just standard of care. It already is in our office, but it will be across the board.
I appreciate that comment because, again, I'm myopic, and if I would have had this when I was a child, I would have had a lot better results than where I am today. I do see a question. Can I go ahead and answer that one there?
Yeah.
The question is,
great.
how late what is the too late of an age for treatment? Teenagers? Doctors?
Yeah. I can take that one. And that's a really good question. And there is becoming more and more evidence out for it. Now, Jenny, correct me if I was right. The MiSight study was 8 to 12-year-olds, correct? And that's what's FDA-approved? Okay, that's a memory there. We know kids are still changing all the way through mid-teens, at least, if not into the upper teens. And that's one thing I still remember. One of my professors in Houston, and Doc brought that up, how we had a couple of professors who kind of created this. He said if it was his kid, he'd treat him till minimum 18, probably 21. I believe more and more science is going to come out on that. But the key is, as soon as they become myopic, that's the time to treat them. We'd be less aggressive if the kid became myopic or nearsighted at 16 or 17 than if the kid was 6 or 7, by all means. But I believe she's 20, and we put her in one of the overnight contact lenses when she was 18 because she just kept changing. But it'll be a lot more common to do it that pre to young teenage years. That will be kind of that best time to start treatment. Really good question.
Okay. Awesome. Well, does anybody else have anything that they want to add or throw in? I think that's all the questions if we want to start to wrap up.
I'd like to jump in real quick. First of all, I'd like to thank everybody. This is really important information, and it's exciting that we have been able to now put it into play, and we can give our patients and our parents of young people the opportunity to learn about this, that it's the norm, and we've got every avenue of opportunity for treatment. which is also exciting. Ginny brings great resource from Cooper and Brilliant Futures. They have a very organized program that we've leaned on to help expand our myopia management. So we've really appreciated that relationship, and it's only going to get bigger. And so we welcome and want patients and parents to ask questions. I think we've developed a very straightforward, streamlined approach so they can learn about it and make a good informed decision. This is new stuff. Sometimes it takes a while to absorb and understand it like anything else. We get that. But our job as to doctors is to recognize when something has changed, it's standard of care, and we have the chance to save vision. We have to implement it. We have no choice.
Awesome. And if you guys do have any more questions, or you're watching the live stream later after it's on Facebook and you have more questions about it, visit duneseye.com to learn more about myopia management. And I think we'll be doing a couple more of these live stream events. And I don't know what the topics are, but we're always open to answer questions, I think.
Fantastic.
So thank you all for watching, and that does it for this one. So long.
Awesome.
Bye.
Great.
Thank you.
Thank you.